Good evening. It is great to have so many of you from across the country join us for our webinar on signs, symptoms, and treatment options for erectile dysfunction and incontinence. This webinar is brought to you by Zero, the End of Prostate Cancer, in partnership with Boston Scientific. I'm Jeremy Patch, Director of Patient Programs and Education here at Zero, and I'm serving as the webinar host. I want to thank our featured speaker, Dr. Michael Granieri, for sharing his time and expertise with us today. I will introduce Dr. Granieri shortly. Before we begin, I'd like to go over a few housekeeping items. Today's webinar is being recorded and will be posted on our website, zerocancer.org, tomorrow. As soon as the webinar ends, you'll see a link to a survey, and we would love for you to participate so we can get your feedback on this event. Tomorrow, you will also receive an email with the link to the recording and the survey. Speaking of surveys, Zero is partnering with Duke University researchers and Pfizer Oncology to better understand the needs of prostate cancer patients. Survey results will help build programs, develop initiatives, and improve patient access in order to produce better outcomes for all people impacted by prostate cancer. Go to zerocancer.org to learn more. For those of you not already familiar with Zero, we are the leading national nonprofit with the mission to end prostate cancer. Zero advances research, provides support, and creates solutions to achieve health equity to meet the most critical needs of our community. We offer an extensive portfolio of patient support programs and educational tools that are offered at no cost to patients and families. If you or someone you know is in need of resources at any time while facing prostate cancer, please share these resources and let them know we are here to help. I'd like to spend just a moment to highlight a few of our support programs. 0360 provides individualized case management to help patients and their families connect with financial assistance, navigate insurance, and find other kinds of support, including emotional support and transportation assistance. Zero also offers peer-to-peer support through our mentor and caregiver connector programs. We match patients and caregivers with peers who've had similar experiences to provide ongoing one-on-one support. Zero Connect is our online private Facebook support group where you can connect with others affected by prostate cancer, learn from their experiences, and ask questions from patients and loved ones across the country. Our US2 support groups are the newest addition to Zero's programming. Support groups are offered all over the country and provide a space for people to connect with others in their community. Virtual support groups are also available, as well as those for caregivers, Black men, gay men and their partners, deaf men, and Spanish-speaking men. On Zero's website, you can find a variety of educational resources, including questions to ask your doctor, patient guides, and up-to-date content on diagnosis and treatment information. There you can also find a nationwide database of sites who offer free or low-cost prostate cancer screening. We also have a full calendar of upcoming educational events. Next week, Zero will be hosting the second part of this webinar series on May 19th. This webinar will discuss risk mitigation as well as treatment advances, including SpaceOAR Hydrogel. On June 22nd, Zero will be hosting Prostate Health, Early Detection, Treatment, and Resources You Should Know webinar. Registration links to these events will be in the follow-up email to this webinar, or you can visit our website at zerocancer.org to learn more. I'd like to take another brief moment to thank Boston Scientific for their generous sponsorship of today's webinar and this two-part webinar series. The Zero team is extremely grateful to you and for all your work for the prostate cancer community. Today's webinar will be led by Dr. Michael Granieri, who will provide us information on incontinence and erectile dysfunction, and will then discuss some possible treatment options to help mitigate these side effects. We will then take questions from our audience, so please feel free to type your questions at any time in the Q&A box located at the bottom of your screen, and we will do our best to get to as many as we can. Now it is my pleasure to introduce Dr. Granieri. He is a urologist at the Conrad Pearson Clinic and has completed a one-year fellowship in male reproductive health and reconstruction surgery at New York University Langone Medical Center. He also received advanced training and certification in male infertility microsurgery at Cornell University Institute for Reproductive Medicine. Thank you, Dr. Granieri, for joining us today. We're excited to hear from you.
Thank you. I'm honored and excited to be here to talk about a subject that I'm very passionate about. I think when you think about the journey after prostate cancer treatments, it can be a challenging journey. And I love what I do in urology because I can help people with their quality of life in this journey. And without further ado, I'd like to talk about what is life after prostate cancer and how is recovery a journey. So the first thing we'll talk about is restoring your continence. Okay, so what should we expect after prostate cancer treatments? Well, unfortunately, bladder leakages can happen after prostate cancer treatments. And it can range from leaking a few drops of urine to uncontrolled streams. Now, the good news is leakage tapers off within several weeks or months, and most patients will regain bladder control within a year. However, we do know that persistent stress urinary incontinence can affect your daily life. I often find that it can affect patients' physical health, emotional health, and mental health, and have a very adverse negative effect on their quality of life day to day. So how common is bladder leakage? Well, we do know that one study found that at 1 year following a robotic prostatectomy, approximately 1 in 10 men still have persistent stress urinary incontinence. And if you're bothered by bladder leakage, you do have options. And I think it's really important to know that and to reach out to physicians who can help you and discuss what options apply or don't apply to you. So here are some coping options. So for people with mild bladder leakage, typically 1 to 2 pads a day, the options are absorbent pads. You can wear adult diapers. You can use an external catheter or a catheter collection device, also penile clamp, and very commonly pelvic floor physical therapy in the form of Kegel exercises. And I find that to be one of the most effective options, especially early on in the recovery from treatments for prostate cancer. For more moderate bladder leakage, typically less than 3 pads a day, there's other options such as injections or bulking agents and a male sling. The male sling is intended to support the urethra and to prevent any leakage with stress maneuvers such as coughing, laughing, sneezing, lifting any objects. And the good news is that most patients can be continent immediately following the procedure. Okay. Now, for more severe bladder leakage, typically patients who have more than 3 to 5 pads a day, we typically recommend discussing an artificial urinary sphincter, also known as an AUS. Now, there's 3 components to an artificial urinary sphincter. There's a urethral cuff, there's the pressure regulating balloon, and then there's a control pump in the scrotum. And this device really does a great job of mimicking the function of a healthy urinary sphincter. And I always tell patients, this is about as close as we can get to your pre-prostatectomy or pre-prostate cancer treatment urination. When you feel the urge to go to the bathroom, and there's just one extra step. You just press the control pump. When you need to urinate, urine flows out, and then it automatically reinflates. So you can just walk away, it automatically reinflates, and you carry on with your day. And I think there's a lot of beauty to this simplicity of this device, and I think it really resonates with patients. Now, how do you figure out which treatment option is best for you? Well, I believe it's important to assess your condition. And there's several ways you can do that. There's a bladder leakage quiz you can take. And also you can document your pad usage or do a weekly journal like a bladder diary. And important safety information and this quiz and more information, they're both available at fixincontinence.com, which is a great resource to help you in your journey. So one thing I would ask the audience is, how would you rate your incontinence? And I would think about this. And at the end of the presentation, you can ask questions based on what you rate your incontinence. Okay, so we're going to switch gears here, move away from talking about incontinence and focus on restoring your sexual health. Okay. So with prostate cancer treatments, we do know that erectile dysfunction is a side effect. And we do know that prostate cancer treatments can affect the nerves that control erections. And it can take as long as 2 years, sometimes even longer, to regain sexual function. Now, a lot of times we do recommend penile rehabilitation following a radical prostatectomy, and that may help the nerves recover or restore erectile function. However, if the ability to have erections doesn't recover after any treatments for prostate cancer, such as prostate surgery, there are treatment options available to our patients to help them reestablish a spontaneous sexual relationship. Okay. And we're going to focus on these treatment options. All right. The first option, which I'm sure many people in the audience are familiar with, are oral medications. The little blue pill, Viagra, Cialis, Levitra. And these may be offered before or after any prostate cancer treatment. The next option is a vacuum pump or a vacuum erection device. And it's here in the top right. And what this device does is it helps increase blood flow to the penis. The next option is penile injections on the middle left. And how that works is you inject concentrated medication directly into the erectile tissue to help increase your erectile function. Another option is urethral suppositories on the middle right. The way this works is you insert an applicator in the urethra and you inject a pellet in the urethra. It absorbs and it's designed to help enhance your erections. The last option on the bottom here is a penile implant, which we will talk about in greater detail. So a penile implant is an inflatable device that uses a pump placed in the scrotum here, and this helps inflate and deflate the implant. Okay. This feels very natural during intercourse. It does offer spontaneity, and it's completely concealed. Nobody will be able to tell that you have the device. It's completely concealed inside the body, and it looks and feels very natural. And in addition, you can maintain an erection for as long as you desire, and you're in full control of how long it stays up for, and then when it goes down. And I think really the biggest benefit to patients when we talk about a penile implant is that it helps give you reliable, rigid erections that you can depend on. And I think that's what resonates most with patients. Okay, so tracking your progress, the journey to restored sexuality and continence. So how do we assess our sexual dysfunction? Well, you can look at things such as the frequency of your intimacy, and there's also questionnaires that you can use to assess your erectile dysfunction. You can find these assessments, more information, and also important safety information at edcure.org. Okay, so there's several frequently asked questions. All right, first one is, how long does it take to achieve bladder control? Well, we do know that stress urinary incontinence is usually resolved within the first year following a prostatectomy. However, it can persist longer than a year without improvement. And one study did find that at 1 year following a robotic prostatectomy, approximately 1 in 10 men still have persistent stress urinary incontinence. I typically tell patients, we should wait about a year. I think that's a good rough guideline to figure out where you're going to settle with your incontinence. Another great question is, why don't all men recover erectile dysfunction after treatments? Well, your ability to have an erection after a robotic assisted radical prostatectomy or any prostate cancer treatment is affected by pre-existing risk factors. These include older age, cardiovascular disease, diabetes, cigarette smoking, physical inactivity, and certain medications such as antihypertensive drugs or psychotropic medications. In addition, there are factors surgically, whether somebody has a nerve-sparing surgery or not. We do know that 1 year after prostate cancer treatment, about 30% of men do suffer from erectile dysfunction. The next question is, are penile implants covered by insurance? I get this question a lot in my practice, and I would tell you that most insurers do cover the diagnosis and any medically necessary treatment for erectile dysfunction and stress incontinence. Now, Medicare does have a national policy for penile implants, although your coverage may depend on where you live. I often find that the treatments for stress incontinence are typically covered, and erectile dysfunction is commonly covered, but a lot of times it just depends on the specific details of your insurance plan and if it's a covered benefit. And I think it's really important for patients to work with their doctor's office and their insurance carriers to check coverage levels prior to any treatments. Okay, so let's talk about real people with real results. And the first patient is Roy. He's a prostate cancer survivor. Roy says, after 7 years with the male sling, I still find the pads in a suitcase or a jacket that I haven't worn. It would be hidden in the pocket somewhere. I laugh and think, thank goodness I don't wear these anymore. And I think Roy's story really resonates with a lot of patients who suffer with incontinence and then who undergo a treatment to restore their continence. They realize, man, I don't have to wear these pads anymore. This is great. All those times I'd have to keep them on, in my suit jacket, in my suitcase. I don't have to deal with that anymore. And that's just great. I find this to be some of the happiest patients in my practice personally. Let's change gears and talk about Barry. So Barry is another prostate cancer survivor. And what Barry says is, prostate cancer surgery has left me both incontinent and with ED. After having the AUS surgery, I could go places again and do things socially without the risk of embarrassment. Now that I didn't have the incontinence problem anymore, I was ready to deal with the ED. When I had the penile implant, I felt completely whole again. It has restored my confidence and restored my life. And I'll tell you, I've heard the message that Barry's saying in many different ways from many different patients. I find that people who get the artificial urinary sphincter surgery feel like they're a new man again. They've been restored. They don't have to worry about what color pants they're wearing, how many pads they are, where's the nearest restroom, do they have a change of clothes, do I have to avoid certain activities on a day-to-day basis that'll cause me to leak urine, and will that be socially embarrassing to me? And when you don't have to worry about that anymore, that's a huge weight lifted off your shoulders. In addition, I find that a lot of patients, when they get the penile implant, they do get a renewed sense of confidence, and it helps restore a really important part of their relationship with their partner as well. So the good news is there's a variety of resources to help our patients. The first is fixincontinence.com. The second is edcure.org. You can also go to the American Cancer Society website at www.cancer.org. the Prostate Health Education Network, the US2 International Prostate Cancer Education and Support Network, and Zero, the End of Prostate Cancer at zerocancer.org. Okay. So there are treatment options for every man. Okay, we do know that with erectile restoration, ED is a common problem. Fortunately, we do know that penile implants are a permanent long-term solution for ED. In terms of urinary control, incontinence after prostate cancer treatment can be effectively managed. And if it lasts more than a year, there are permanent solutions that can help restore your urinary control and function. And it's really important to take away from this. What are the next steps for me? Well, I would say talk to your partner, your loved one, family, and just figure out what would be best for not only you, but also your partner in their relationship. And then also talk to your doctor about potential solutions for both issues, and if they apply to you, and which one you guys would think would be best. There's a whole lot of treatment options out there to help our patients, and taking those next steps is really important. Okay. At this point, I'll turn it over to the audience and take any questions.
Yeah, we've got, that was great, Dr. Granieri. Thank you for that presentation. We have got a lot of questions come in, but I'm not surprised. We've got a lot of people on the webinar. So first question we can just start with is, do you have patients reporting intense pain during orgasm after a radical prostatectomy?
Yes, that certainly can happen after radical prostatectomy. A lot of times it depends on how soon you are after surgery, but unfortunately that can happen. But typically I find that with time it should improve, and there are some medical options to help with that as well. And I think talking to your urologist about what those options could be would be very helpful.
Can someone who has had CABG surgery use any ED option, including oral medication?
Right. So patients who have cardiac surgery or a CABG, that's essentially heart surgery. With those patients, I find it's really important to talk to your cardiologist just to determine if you're healthy enough to undergo sexual activity. As urologists, we have certain criteria called the Princeton criteria that help guide us to say, is your heart strong enough to undergo sexual activity or the stress of sexual activity? And could you tolerate any treatment options or medications? So I think working both with your urologist and your cardiologist to determine if you're healthy enough is the first step.
Okay. And there's a somewhat related question. How old is too old for something like a penile implant?
Yeah, that's actually that's a great question. I get that question not infrequently. My general view on that is I don't look at age as much. I look at your health, and if this is something that's important to you and your partner and an important part of your quality of life. I see people at all ages, and some people who are young aren't interested, some people who are older are. And I feel as long as it's medically safe for you, you could undergo the surgery and it will help your quality of life, and you have thorough counseling ahead of time. I don't look at age as much as a limiting factor.
Okay. This person says, I believe that only 3 to 5% of men who have ED after prostate cancer treatment opt for a penile implant, and correct us if that's wrong. Why is the rate so very low?
Yeah, so I feel like a lot of it depends. Sometimes they may find success with other treatment options besides the implant. As we talked about, there's pills, injections, vacuum device, and suppositories. Sometimes patients have lost interest in making that a significant part of their life, and they don't desire to pursue any treatments. And then sometimes they don't know about the different treatment options. They're not presented to them, they don't have access to a specialist who does, erectile dysfunction surgery or incontinence surgery as well. So I think there's a lot of different factors that may lead to it. I think the penile implant can be underutilized, and certainly it's important to make sure that if you are struggling with erectile dysfunction after prostate cancer treatments, that you do know that you can go see your doctor or a urologist, and there are treatment options out there to help you, such as penile implant.
Thank you. How common are inguinal hernias after prostate cancer treatment?
Yeah, I don't find that it's that common after treatments for prostate cancer, not after radiation and not typically after prostate cancer surgery. Sometimes we can detect them at the time of prostate cancer surgery, but I think it's a very low rates.
Okay. And these questions, I'm just going off in terms of when they came in. So
Yeah.
apologies if you address something a little later that may have after the question came in. But so this person says, you haven't mentioned bendable or no pump penile implants. I currently have an AUS and I'm considering a bendable penile implant. Do you have any experience with installation of these? Do most men achieve favorable results with bendable penile implants?
Yeah, so I think this question is getting at the malleable penile prosthesis. And I know our focus today, or what we talked about, was the inflatable penile prosthesis, but the malleable penile prosthesis is a fantastic option. And I have a lot of experience placing them. And I think for the right patient, it's a great option. Some patients who really benefit from it are people who maybe don't have good hand dexterity to squeeze a pump, or perhaps they just want something simpler where they don't have all these different parts and components. I see a variety of patients who maybe due to their age, they have arthritis in their hands or other medical conditions like Parkinson's, who still want to be sexually active, but can't operate an inflatable penile prosthesis. And there's other patients who just, prefer the malleable over an inflatable. They just like the simplicity of it. So, I feel if it's something you're interested in, certainly talk to a urologist who specializes in that surgery and really sit down and talk about the difference between the two options and which one would be best for you.
What does the data show for patients that have had both, they say both the operation, I assume they mean a radical prostatectomy, and remedial radiation? Does the incontinence tend to get better with time?
Yeah, so a lot of it depends on when you get your radiation treatment after prostate cancer surgery. So typically I'll tell patients after you have surgery for prostate cancer, usually a rough guideline is about a year. At about a year, I think you'll kind of settle out where you're going to be in terms of your pads per day. If you get radiation a year plus after prostate cancer surgery, that may actually worsen your incontinence, and it may worsen stress incontinence or cause new incontinence like urge incontinence. If you have radiation early on, it, I think, typically can worsen your incontinence. And a lot of times when I have patients who do need radiation, we try and wait until they've actually achieved continence before we consider radiation.
Okay, thank you. And there's a couple of questions, and there's probably more further down, but one person says, maintaining an erection is not the same as achieving orgasm. Can you comment on restoring orgasm? I'm going to throw a second part in there. There's a question about related about ejaculation as well. So similar. Can you address those, ejaculation and orgasm?
Yeah, so is this in a patient who's had prostate cancer surgery? I assume so. Yeah, so I think when you think about all those different components of the sexual experience, the first is you got to make sure that you can get reliable erections and you have a treatment that works well for you and that you're comfortable with, and that your partner is also comfortable with too. In terms of orgasms, a lot of that depends on other situations beyond just the mechanics of achieving an erection. And then with ejaculation, in the patient population who've had prostate cancer treatments, a lot of times, especially if you've had prostate cancer surgery, you'll have dry ejaculations or dry orgasms where you'll orgasm but no semen will come out because those structures have been removed during the prostate cancer surgery. So they're all intertwined, but it's very complex, and there's many different factors that go in with all those different components.
Just filtering through the questions here. What steps can be taken to reduce or eliminate leakage during sex? I am continent otherwise.
Right. So a lot of times it depends on how far you're out from your treatments for prostate cancer. Kegel exercises, strengthening your pelvic floor. I always recommend that to patients. I find that's a fantastic option. The more they can do, the better. If that doesn't provide the results that you need, and your pelvic floor is not strong enough or your sphincter muscle is not strong enough, there's other options such as sling, artificial sphincter as well.
Okay. And I mean, I think the pelvic floor exercises are a good example of a possible treatment option. Is that type of physical therapy typically covered by insurance?
Yeah, I find that typically it is covered by insurance. I haven't had any issues in my practice referring patients for pelvic floor physical therapy at all. So
Okay, good. Can the AUS and penile implant be combined in one procedure?
yeah, yes, they sure can. I do that procedure. I know many urologists do. It just depends on the patient. If they decide, yeah, I want to have everything done at once, you should talk to a urologist who's experienced in doing both those together at once. There's pros and cons to doing them in a staged fashion where you do one first and then another one down the road several months later versus doing both of them together at the same time.
There's a question on here, just somebody asking if you could please just kind of go highlight again the treatment options for incontinence. Could you
Sure.
just wrap that, summarize that again for us?
Yeah, so I think when we talk about the treatment options for incontinence, I think about them as non-surgical options and then surgical options. So the non-surgical options would be things like pads or diapers. Also, external catheter collection devices such as a condom catheter, a penile clamp, and then Kegel exercises or pelvic floor physical therapy. I think those are all fantastic options, and I have patients who will, do them either temporarily and then, get their continence restored, or sometimes they choose to use them permanently. I have some patients who will use pads, 2 pads a day, and they're comfortable with it indefinitely. The surgical options, typically, you have urethral bulking agents, where you inject some bulking agents around the urethra to help support the urethra and helps, improve your incontinence. There's also a male sling, and that really helps reposition the urethra and acts like a support or a hammock for the urethra. And then there's the artificial sphincter, which, as its name implies, it mimics the natural sphincter muscle of the urethra. And so that's kind of how I think about it. Non-surgical and surgical options.
What percent of men, and you may have covered this, but what percent of men will suffer severe, moderate, and low incontinence after robotic surgery?
Yeah, so that's a good question. It's, it depends on how you define, low, moderate, and severe incontinence. But we do know that about 1 in 10 men will have incontinence that is bothersome enough to them. So we're looking at about 10%, and that may be underreported. I mean, if you look in the literature, you'll find wide ranges of incontinence. So, but roughly, you say 10%.
Okay. Is it common to regress with incontinence after prostate surgery and the cancer becomes metastatic hormone sensitive with ADT?
So, I see a lot of times that patients will kind of stabilize or plateau. But sometimes with age, as we get older, or if you have any weight gain or other factors that go on, or you have other treatments such as ADT, you may notice a slight increase in your incontinence with time. I've seen people who have been at 2 to 3 pads a day for years, and then they started having about 4 pads a day and started bothering them. They wanted treatment for it. So that certainly can happen. Typically, you would find that things should stabilize at about a year or so, but there are patients who notice some slight worsening as time goes on.
You mentioned early in your presentation penile rehab. What does that involve?
Right. So penile rehab or penile rehabilitation is helping improve the blood flow to the penis after prostate cancer treatments, typically prostate cancer surgery. So that's taking pills such as Viagra, Cialis, trying to stimulate the penis as much as possible, even if you're not getting full erections, just trying to really help increase the blood flow, using a vacuum device as well, sometimes doing injections early. You're doing a lot of different options to help really rehabilitate the penis, to help restore its erections to where closer to where it was before surgery.
And I've seen this question a couple of times now. Is ED more common after radiation treatment or after surgery?
Yeah, so it depends. You can say roughly, they're fairly similar. A lot of times with radiation, you may notice that it can kind of progress over time because the effects of radiation can be longer lasting. Typically with surgery, you'll notice that immediate effect on your erections right after surgery, and it takes some time for it to improve. But I'd say roughly about equal, but a lot of it depends on, who your radiation oncologist is, who your prostate cancer surgeon is, your pathology, and exactly what details of their treatment that they're going to provide you.
Are there options to repair nerve damage?
So there's been studies looking at a variety of different options to help repair the nerves after prostate cancer surgery. People have used different devices, stem cell related things to wrap the nerves. There hasn't been any durable, super effective option to really repair the nerves and restore your erections in the majority of patients. A lot of times the nerves, just with time and stimulation, will improve with time, but there's no guarantee, and there's not a very clear-cut way to restore the nerves or repair the nerves.
Does prior radiation cause complications for sling and/or AUS surgery?
Yeah, so that's a great question. The patients who've had radiation for prostate cancer, typically I won't place a sling on those patients because I find it to be less effective and you have a higher risk of complications such as erosion. For people who need an artificial sphincter, or those patients typically, you do have a slight increased risk of erosion because the tissue quality is not as healthy, or just a little bit of atrophy or wasting of the urethra. So in that patient population, you kind of have to, adjust your technique a little bit because you do know that a radiated field is different than somebody who's not been radiated, and the tissue quality is not as, say, robust as somebody who has not had radiation. So in summary, for people who've had radiation for prostate cancer, I typically would advise not to do a sling and to place a sphincter, but to be mindful of the fact that it had radiation. And to discuss that with the patient and explain to them, hey, this does slightly increase your risk of complications.
Penile implant surgery and the cuff to control incontinence seem like major surgery. What is the recovery process like?
Yeah, so I'll start with the artificial sphincter surgery. So typically, I do it as a same-day surgery. So this procedure takes about an hour. You go home the same day. Typically, you can go home without a catheter, and you're leaking urine for about 6 weeks. All right, so the device is not turned on for 6 weeks. I don't have patients lift anything over 10 pounds or submerge their wounds in water for about 6 weeks. And then after 6 weeks, we turn on the device. Okay. For the penile implant surgery, I also do that as a same-day procedure where you go home the same day. Typically, the device is left deflated until about a month from surgery, and then about a month from surgery, you start inflating the device. But typically, for people who've had a penile implant, you're not going to do any heavy lifting over 10 pounds for about 4 to 6 weeks, and you're not going to be submerging your wounds in water for about 4 to 6 weeks until all your incisions have fully healed.
Okay, thank you. That was a good question, and I think that was probably helpful to walk through that for a lot of people. Are there good low-risk options for bladder neck contracture?
Good low-risk options for bladder neck contraction.
Probably contraction.
Oh, probably contractures.
Contractures, yeah, contracture.
Yeah.
Sorry.
So bladder neck contractures, that's essentially just scar tissue where the urethra and bladder neck are put together after prostate cancer surgery. There's options such as dilations or incision of the bladder neck to help open it up, self-catheterizations as well. I find those to be lower risk options, but that can be a challenging and difficult problem. So you always want to make sure you talk to a urologist who has a lot of familiarity with bladder neck contractures.
Is there a known pattern of use for the different ED solutions? So maybe progression.
Yeah. So a lot of times it depends on who your doctor is and how they kind of take you through that journey. But I find typically patients will always try pills first. I find that they're the first line therapy, lower risk. And then once pills don't work, usually they try one pill. If that doesn't work, they try another pill, and they kind of struggle with pills back and forth for a while. After pills don't work, usually they get a referral to a urologist to talk about other options. At that point, typically most patients will want to try one of the non-surgical options, vacuum device or penile injection therapy. Rarely do I have patients who are as interested in the urethral suppositories, but I have some. And a lot of times they'll try these other therapies and see if they work well for them and provide durable results. And this process can take months or sometimes years and years and years and years. And eventually, if patients find that they're not satisfactory or they're ineffective, then they'll have a discussion with their urologist about a penile implant.
I'm just scrolling, trying to find a good question. And there are lots of good questions, but
yeah.
What this question is, if the ED implant fails to deflate, what is the parachute escape option?
Well, right. So I think you need to call your urologist if it fails to deflate and make an appointment immediately and see them, because typically at that point, they should be able to troubleshoot it in the office. I've seen this situation before. always say just come on in, get evaluated right away, and you can usually deflate the device. I haven't seen it progress beyond that.
How long does a penile implant last, and when does one choose that option, if at all?
So typically, the penile implants can last about 15 to 20 years, so they're quite durable. And in terms of choosing the option for the penile implant, a lot of that just depends on your specific factors and your specific discussion with your urologist to figure out if it's the right treatment option for you and when that time would be for you.
What are the benefits of a male sling versus the other option you presented?
Yeah, so if we compare the male sling to the artificial sphincter, I really think the benefits of the male sling is it's hands off. So once it's in, there's no kind of maintenance required by the patients. And so I find that to be quite nice for a lot of my patients. The downside is it's less effective for higher volume leakage. So typically anything over 3 to 5 pads, it's going to be less effective. There are some patients who don't have, who leak a lot of urine, but don't have either the good cognitive function or hand dexterity to safely operate an artificial sphincter. So that's where I think a sling can be very effective as another option to help those patients with their urinary incontinence.
This question is, following radiation, is fecal incontinence an issue, and what can be done about it?
Right. So yes, fecal incontinence can be an issue after radiation for prostate cancer. A lot of times, you can try conservative therapy. You can try different medications as well. A lot of times I'll refer people to a gastroenterologist, or they talk to their radiation oncologist about it. Sometimes people take steroid suppositories as well to reduce any inflammation in the rectum. But if you have really severe, long-lasting rectal incontinence, you can also consider something like an InterStim or other therapies like that as well. But a lot of times you want to make sure you talk to a gastroenterologist about that if you're having persistent long-term fecal incontinence after radiation for prostate cancer.
So one person says, I ejaculate, but it is urine. Is that normal?
So for patients who've had their prostate removed for prostate cancer, that's something that we commonly know is called climacturia, where when you orgasm or ejaculate, urine will come out instead of semen. And we do know that it's something that can happen after treatments for prostate cancer.
Can you recommend some resources for Kegel exercises?
Yeah. So I always tell patients, number one, talk to your urologist and make sure you get a referral to a physical therapist. I find that they're fantastic resources to help you, keep you on track, give you a lot of tips and tricks with their experience. In addition, you can go online, go onto Google and say Kegel exercises. There's plenty of websites out there with brochures of how to do Kegel exercises. And also you can simply just go to YouTube as well and find instructions on YouTube of how to do Kegel exercises. There's numerous different sites that have a lot of great options. And I always recommend that to my patients, just, physical therapist, and then do it at home based on what your physical therapist tells you, but also what you can find online as well.
One side effect that wasn't mentioned, but somebody's asked a question: can anything be done about hot flashes?
So hot flashes will typically occur when you're on androgen deprivation therapy for metastatic prostate cancer. And there are medical options for hot flashes. And I think that's something you want to talk to your urologist about to discuss, what those medical options are and what they can do to help you. But yeah, I've had patients with hot flashes who've been on androgen deprivation therapy and prescribed them certain medications to help really minimize the symptoms of hot flashes.
How successful are each of the surgical options you described? So
Yeah. So I think if we're going to start with erectile dysfunction first. So we'll talk about penile implants. It depends on how you define success. But if you look at patient and partner satisfaction, I mean, we're looking at 98% plus. And typically we do know that at about 7 years, about 90% of patients are still using their implant without a problem. So I find that penile implants are a very, very successful option with high satisfaction rates. All right, but you have to carefully select for the right patients. With artificial sphincters as well, I think you're looking at similar success rates, 90+% in the hands of a skilled urologist who can do the artificial sphincter surgery well. And I find a lot of times those patients who get the artificial sphincter have some of the highest degrees of satisfaction and just overall success because people can go from 10 pads or 10 diapers a day to completely dry, and that's life-changing. And then, when the sling is selected for the right patient, it's also very effective. I just find the key for a lot of this is making sure that, you talk to your urologist who specializes in this area, can help guide you as to what option will be best for you.
do robotic prostatectomies have any significant advantage or disadvantage concerning incontinence versus open prostatectomy procedures?
Now, this is a great question. It's been a long debate, with among many different urologists, people who perform the robotic versus the open. And the general thought is a lot of it just depends on your urologist and how skilled they are with either technique. And I find if you find a urologist who's very skilled with the open technique, who can perform a good nerve spare or minimize incontinence, that can be just as effective as somebody who's very skilled with the robotic surgery. We do know that with the robotic surgery, there typically is less blood loss after surgery, and also a little bit of a shorter recovery time, or a little bit less pain as well because of the minimally invasive approach. But I think in the right hands, either option would be great, could give you successful results.
Okay, and I'm going to add on the question right next to it is very similar. Can you add on the side effects of radiation to the question is which treatment has less side effects, surgery or radiation? So
I don't know if one is less side effects versus the other. A lot of times you have different side effects. So with radiation treatment for prostate cancer, you can experience erectile dysfunction. You have a little bit lower risk of stress urinary incontinence, but you can get other urinary symptoms such as radiation cystitis or irritation of the bladder that can cause bleeding. You can get overactivity of your bladder, urethral strictures, radiation proctitis, or irritation of your rectum as well. With surgery, I mean, there's general surgical risks, infection, bleeding, any scar tissue or bladder neck contracture, and then erectile dysfunction, stress urinary incontinence. So, it's they have some shared side effects such as erectile dysfunction and incontinence, but then there's a lot of different side effects that they have as well.
Do you recommend any drugs to treat incontinence?
So for stress incontinence, there's no, I don't really or typically recommend medications or drugs because it's more of a structural problem. However, there are different types of incontinence, such as urge incontinence And in those patients who have urgent incontinence, where you get this sudden urge to go to the bathroom, you can't postpone it, a lot of times medications can be very successful, but that would be a talk for another day.
Okay, I think we're gonna do, let me search here for the final question. We've got a lot more, but there's just no way we can get to all of these. So I'll finish with this. My surgeon mentioned physical therapy treatment for incontinence, which perhaps is the Kegel exercises you were talking about. How effective do you think this is?
Yeah, I think they can be very effective. I always recommend it to every patient who undergoes prostate cancer surgery. Once we make the decision to undergo prostate cancer surgery, I tell them, start your Kegel exercises today, continue throughout surgery, and continue to do it indefinitely until you're dry. And even when you're dry, just continue it for a little bit longer. I find that they can be very, very effective. I mean, there are obviously and unfortunately some patients who will do Kegels and don't get fully continent. And that's just where all these other options come into place as well. So,
Okay, well, thank you. I mean, that really brings us to the end of the hour, but I really thank you, Dr. Granieri, for an
yeah.
informative presentation and answering all of our questions. Thank you to our sponsor, Boston Scientific, for sponsoring this informative topic. To close our webinar, I want to remind everyone that Zero is here with support that is offered at no cost for both patients and caregivers, and you can learn more at our website at zerocancer.org. This is the conclusion of our webinar. As a reminder, you will receive an email with a link to this recording and a short survey to share your feedback. Thank you for joining us and have a good evening.